DAMA held this startup on a mission to eradicate the trial and error, the women's health, in a simple one question. But we're starting with contraception, and we're looking into how we can personalize who gets what type of formulation, dose. We have like 13 different methods in the UK, 200 different brands, and usually we don't know. Like usually people just, oh, contraception is just a pill. But actually there's so many methods and there's so many different ways around going beyond just preventing pregnancy. It's a very complex equation actually for everyone to think about, like, what are the risks of this medication? What are the benefits for me? And what is my decision is really, really individualized. That were actually linked to side effects related to mental health, which is another very controversial topic, and we haven't been able to, have a conclusion on, mental health and contraception. But again, we think that for some people with risk factors of specific, maybe genetic or the other issues as well, they might be actually at risk of developing this mental health side effects. When you're making a decision about contraception, it's right now, but also me in the future, right? Like it's also going to potentially affect like my relationship, my fertility. So it's a big decision to make actually.
But at some point, we have to introduce ourselves. Michelle, I think we already know who you are.
I'm not sure we do actually. I've never introduced myself on this show.
You've never introduced yourself on this show. Do you want to introduce yourself now?
Why not? So, hi, I'm Michelle. Started off as a hospital doctor, as a psychiatrist for 10 years. Now work in business. Been working in business since 2004. And work across healthcare, life sciences, and education. And as a hobby job, I am an angel investor and advocate for everything in terms of female health. And I love the startup community. So that's a little bit about me.
Okay, awesome. And to our guest today, Paulina, please let us know.
Sure. After Michelle, I think it's very difficult. It's like the big end spot. So I am a medical doctor by background as well, but I only did 1 year of practicing actually as a doctor. Well, I still technically take shifts here and there, but very rarely. So on my sort of career journey, I wanted to become a global health doctor. I wanted to do MSF, WHO, that kind of stuff. Very quickly, I realized there's a huge wave of innovation and technology that will have a huge impact in medicine. So then around year 3 of med school, I started getting involved with startups. I worked part-time with different startups. Plan was to do a bit of both in life. I tried to thinking that I could do a bit of both in life. So do medicine clinically and work in startups. But then I met the right people at the right time, and I was working on a project in women's health. We were working on improving contraception consultations with primary care clinics in London at med school. And I actually went to business school as well. And there was part of me that was just like, let's explore this interest I had. And at business school, I met my co-founder, Elena. She was looking into the science of contraception as well, looking into hormone testing, genetic testing. Can we improve the personalization? She was looking at this from the PhD angle as well. Could she go down the route of studying this a bit more further? But then we were both in business school. So then thinking about the problem, we actually started thinking about it more with the business mind of actually we need to have investors and industry coming in to support this project rather than just academia taking 10, 15 years. So we started a company when I was still in med school. Now I'm a CPO, co-founder of DAMA Health. So DAMA Health is a startup on a mission to eradicate the trial and error, the women's health, in a simple one question. But we're starting with contraception, and we're looking into how we can personalize who gets what type of formulation, dose, contraception based on their individual factors to meet their needs.
I'm going to ask a really dumb question. What is contraception for women?
Oh, this is actually a very good question because it's such a different thing for everyone. So for some people, it's very much just safety net of preventing pregnancy. It's very much, I definitely don't want to risk it, and I'm going to use contraception to prevent pregnancy. But for so many other people, it can be so much more. So for example, for an athlete who is really struggling with the periods, contraception can help you with your menstrual periods, right? The pain and the bleeding, and actually they use it to control and sort of stabilize their hormonal health through the month. Then for someone who has endometriosis or PCOS, actually contraception can be prescribed as a treatment as well because it regulates your hormone cycle. So there's so many different types of contraception, and it's been around in the market for 60 years. So the main concept is really to prevent pregnancy. It really improves reproductive autonomy for people as well. But now we're getting into an era of, is contraception really good? Can we get novel, better methods of contraception? And then how do we actually personalize who gets what type of method as well, to really see whether people should be on a specific method or not, right? Is actually natural cycle more appropriate for you? So it's a whole range. We have like 13 different methods in the UK, 200 different brands, and usually we don't know. Like usually people just, contraception is just a pill. But actually there's so many methods and there's so many different ways around going beyond just preventing pregnancy.
Okay. I'm a man. So for us, that literally just means one thing. Why are there so many different types of contraception for women?
So initially, there was only a few methods that were developed very initially, but then we were thinking about, can we create longer term methods? Because the initial one was just a pill, so you take it every day, but people can forget about the pill and the effectiveness can be lower. So then there were longer term methods developed as well. So the implants, the IUDs, injections, to really give people a bit more safety net as well, in thinking about, without coming back to your appointments, coming back to your doctor, can we develop something that's a bit more long term? And just to give more options to people, right? And I think we actually don't have enough options still, because all these 200 different brands are essentially like fairly similar. It's two types of synthetic hormones, right? So actually, can we create even more novel methods? And they're already on the market. So there's new things like new shapes of IUDs. There's things like non-hormonal gels and creams as well that are being developed. And we're still studying this, and because there's not enough like research, I guess, and innovation and money coming into the space to develop them fast. But they're still coming on the market. And there's actually male contraception coming on the market as well.
Is that right? Okay.
Would you take it?
I mean, I guess it depends on what it is.
Yeah.
I'm not keen on needles and stuff. So, but yeah, it really just depends on what the administration process is, right? And that's probably true of most people. We're probably comfortable with different things. Listening to you there, because I've never had to think about any of this stuff, right? Not from a female perspective, anyway. And I suppose we don't get into, men will generally not get into these conversations with women. Women probably don't want to talk to men about it. But what is the education like around this whole area, and like how well are we doing in terms of informing women about contraception and what options are available to them?
Yeah, it's a great question. So I think very often you either dragged by your mom to your GP, right, to get your first contraception when you're like 17, 16. So like to get something for your mom's peace of mind. I think there is sex ed going on in schools. I didn't grow up here, so I don't know in terms of education in the UK around contraception. But very often we are kind of relying on that GP appointment in that 10-minute slot when you go get your contraception to get all the education on contraception. And very often you're referred to like, just read online a bit about the methods, just to go on NHS website. There's like a few educational websites that you can go and read about, because it's just impossible to get all the education in 10 minutes when you see your GP. But actually that's where you would trust your doctor to give you that information. But it's just so little time to explain all these different methods and the impact it can have on you, and then arrive at the short decision of the patient, because it's very individualized and personalized. So impossible to do in such short period of time. So obviously there's a lot of information online, but the problem is you go online, you have 13 different methods, a million pros and cons of each. Like you still have no idea which one is actually going to be good for me. Like my mom reacted like this, my sister reacted like this, my friend reacted like this. No idea what's going to work for me, right? So then you have social media, which is another issue in terms of the same story of like this worked for someone, but it's not going to work for me. And there's a lot of like concerns and misconceptions online as well, which is fair enough. Sometimes, there's a study published on a topic, but it's not high quality study, for example. And then there's a huge social media concern around contraception as well right now that we're sort of battling with as well. So there's so much information going on at people from different perspectives, and it's really hard to make like an informed decision for yourself. And in schools, I think maybe it's becoming a bit more of a topic beyond just preventing pregnancy, that actually it is something that you can use to help with your periods. But yeah, I'm not sure if we're doing it very well from the very early on. And also for boys, I think as well, I think still we're separating girls and boys when we talk about these things. And I think maybe the trend is a bit more to start talking to people as couples and, being the partners as well, who's going to take this responsibility, what it means for the couple. Like for some people, contraception means that the libido is a bit lower as a side effect. So it's things that actually like probably males and just generally partners, whether the gender should be involved with as well.
And so how does DAMA actually educate people, or how does it work with DAMA?
So with DAMA, we actually took the B2B approach in the sense that...
So B2B is business to business, right?
Yes, business to business, because we were looking at this market thinking, obviously you can sell contraception directly to consumers as well and sort of create this service company, and you have a lot of telepharmacies doing that. But we actually really believe that people still want to speak to their doctors about this. So to really make that informed, shared decision, like it's still going to be with the doctor. So instead of sort of launching big campaigns and direct-to-consumer selling contraception, we partner with clinics and doctors who already do it, so they can do it better in a more personalized way. So the way we work is that we have a platform for every patient that goes to see their doctor. They go through this platform, they fill out a holistic assessment of their needs. On average, people engage with this for like 15 to 20 minutes. We collect 150 data points about this patient, and then on the back end, we analyze all of that to match them to the methods that work best for them. But that information, the medical information, gets to the doctor versus the patient gets like personalized insights related to contraceptions. For example, if someone tells us, I want contraception to help me with acne, or I want highest effectiveness, I want something discreet. There's so many different things about contraception to look into and to take into account. We would tell them which method actually does these things for them, so they only get those like insights that matter to them based on what they said was important, because it's just overwhelming to read like 20 articles about all the methods. So it's like just what you kind of told us is important. And then they go to the doctor. The doctor has their like medical analysis of our algorithm, and they have a more shared decision on what to choose for their needs and for the preferences that they told us they had. So this is the first step. But at DAMA, we have this research and development arm as well. And this is how DAMA started, thinking about there's so much more about women and metabolism that we don't understand in terms of contraception. And actually, there is genetic variability as well that comes into play. So all of us have such different genetic makeup. But there's research showing that actually it can predict the response to contraception and who develops side effects. Our hypothesis that is the genetics, the lifestyle, the medical history, all of this together can really predict treatment response. But that's what we're studying on the side as well. And in the future, what we want to see is taking this really holistic picture for a woman, genetics all the way to lifestyle, and then making treatment decisions of contraception, but also HRT, women's reproductive, all the other therapies that are coming into market. But this is where the medicine is going, is just how do we get there with the baby steps that we have right now.
So poor general practitioners, right? The big ask to prescribe, try and take in all of that wealth of kind of data out there, and then try and get the right medication to the individual in front of them. I guess that's the same for all things which they're prescribing. But I can imagine with anything hormonal, the variation is much wider.
Absolutely. Yeah.
And so how do you see, what feedback, I guess, do you get from the general practitioners in terms of, and maybe it's different in the UK to other countries?
Yes. So we are focusing mostly on the US market right now, but the doctors actually were every country, the answer I always get is the same. Like, if we could predict women's response, it would be amazing, like revolutionary. But they just exactly, it's just impossible to do right now. But we do it with other areas of medicine, right? Where there's a lot of investment, like oncology, like personalized medicines, that cardiovascular disease, antidepressants. Like, we definitely see like more progress around these areas. So it's going to happen as well. But before we can predict, can we already do better with that informed consent to contraception, shared decision making, taking things into account that we know we have to take into account before the research gets there. And yeah, GPs, that's how it all started, because I was basically just a medical student doing GP placement in one of the locations around like UCL, and it was just crazy. Like every other visit was almost like a contraception visit, because it was such a high student density population area. And it was like such a struggle. Like people were, the student was a bit uncomfortable, the doctor was a bit uncomfortable. Like, I can't tell you all of this right now. And it's like, let's just try the pill. And then, they come back very often, they don't like the pill. And actually the stats on this, that on average, we tried 3 to 4 different types before finding the right method. Around 30% of women stop contraception the first year because of the side effects, or just not fitting their lifestyle anymore. So a lot of people switch a lot, or just stop and never come back. And then this whole hormones are not good for me happens as well, which might be the true, but it's just we didn't give it a chance of finding something that actually may work for you very well.
You mentioned earlier when you were describing the process and you said 150 data points. That sounds like a lot.
Yeah.
What exactly are we looking to learn from 150 data points?
Yes, good question. So actually, the medical history you have to take into account for women taking contraception is really long. So around 100 points are just medical history. So there's a lot of things to take into account that are related to cardiovascular risk factors. Getting like black clots, for example, is one of the risks of being on hormones and contraception. So you have to assess, are there any other risk factors? So a lot of this actually could just be like, no, the patient doesn't have any problems, but you still have to take this into account. So usually doctors would like just screen for the most important things, like do you have migraines with aura? Do you have any history of blood clots, anything like this in your family? But actually when you look at the medical guideline, there's like so many conditions that you should be screening for and taking into account. And then we have the section on the lifestyle and goals and their past experience. So we take all of that into account. So the lifestyle is things like, are you looking for something long-term? Are you okay with injections, as you mentioned? Like all of the things that matter and to choose which type of method. And the goals are things like, do you care about periods? Do you want them? Do you not want them? Acne, like do you need your hormonal contraception to help you with that or not? Things like PMS, like do you suffer from PMS? There are a lot of things that contraception does beyond preventing pregnancy we take into account, and the past experience as well. So we actually can learn a lot. This is probably the best actually insight into how people respond to contraception is just based on past experience if we don't have any other like biologic, hormonal, genetic testing. So if you responded very badly to this progestin but responded quite well to another progestin, that gives us really good insight into how you might be responding to these medications going forwards.
Wow. I would have had no clue that there was such a process to go through. I mean, for us, it's literally, go to the store, buy a pack of condoms, and then the most complicated part is somebody learning for the first time how to put one on, which isn't like massively complicated. But yeah, we as blokes, we generally tend not to think too much about female contraception, and a lot of the times I guess it's sort of seen more as like a man's responsibility to use contraception. For women that kind of don't want to, is there any downside to that, or is there any obvious benefits of them using contraception if we're talking about preventing pregnancies?
So any other benefits beyond preventing pregnancy?
So like if you're in a relationship or you're in a couple or whatever, right? And you're a woman and you're just sort of saying, you know what, I'm not going to do anything. The guy will use contraception and will be safe, right? In terms of I've got much lower risk of catching any sort of sexually transmitted diseases. I've got much lower risk of getting pregnant. Is there anything wrong with women taking that approach?
No, absolutely. I think the whole thing that we're trying to preach is that there is no right or wrong with these things. There isn't that thing that everyone should be on a pill, everyone should be on IUD, everyone should be using condoms. Like, it's so individualized. So, some couples just don't like using condoms. And there's actually a lot of couples just don't like that. And then in terms of like long term as well, if you don't want to get pregnant, in the next 5 to 10 years, like, can you do something more effective? So some people just prefer that as well. And actually there's also benefit of thinking, maybe if I'm not using it for birth control at all, in terms of like preventing pregnancy, a lot of girls use it for acne, PMS, like just other hormonal imbalances as well, which is also arguable. Like, is this the right thing to do? Like, we're still thinking maybe some of these things could be managed with like more lifestyle interventions as well. But it's very, very individual. It's like also contraception prevents from like vulval, ovarian, and endometrial cancer as well long term. So it's a very complex equation actually to like for everyone to think about, like, what are the risks of this medication? What are the benefits for me? And what is my decision is really, really individualized.
I suppose that's very much like any drug.
Absolutely.
Yeah.
Absolutely.
And where do you think it will go in the future? So for instance, on the assumption that, DAMA is going to scale and go to lots of different countries, which I'm sure it will. Where do you see its future?
Yes. So an ideal future, I would want to have a very like sophisticated way we match people and women to medications. So again, looking at it from the genetics to lifestyle, sort of those algorithms that really can predict which medication would be best for you across women's reproductive health, but also just beyond hormonal contraception, right? So we have novel therapeutics coming into market as well in the next 5 to 10 years that are addressing things like ovarian aging and longevity, and also thinking about non-hormonal, like there's immune modulators now. There's like a lot of new things happening, and I think like this is like definitely thinking future, but like ideally like being able to look at all the different options, and also the very, condoms still being there and the natural family planning still being there, and really being able to make more informed decisions like faster and better. I think that right now we have just an overwhelm of information, poor scientific papers, or like just a few papers that we can take into account. And the papers are also always obviously like you study a group of people and then you study a lot of people, and actually maybe in the future we'll be going into studying just an individual as well, right? Because we study a group of people and you say on average there was no effect, but actually for some people there was an effect. So I'm definitely thinking that maybe in the future we'll be studying women a bit differently maybe as well. And so far we haven't been studying women generally very well anyway. So yeah, hopefully a bit more individual, personalized research aspect on this as well, so we can make very like informed, personalized decisions and for women with reproductive health.
And to get there, because you're right, it will take time, as all research and development does. Have you already started with, or are sort of people able to sign on to get their genetics tested with DAMA, or is that part of a separate research?
Good question.
setting?
Yes, for now it's separate, because there's definitely things you can do, and you can launch a genetic test with some variants that are well known, and you could make some extra decisions around contraception based on them. So for example, we could test people on your individual risk of blood clots, your risk of having depression, blood collagen, and risk scores that could be related to choosing contraception. But what we're doing at DAMA is very novel, looking into like the metabolism of contraception and specific variants related to contraceptive response. So that's going to take time to bring to market in terms of regulation, approval, and actually showing clinical trials on this. There was a bit of a way around this in the US in the last few years with clinical developed labs, where you can just launch something and the results would be sent to the doctor and they could interpret it and read it, and they basically had to deliver to the patient, so all the responsibility was on the doctor. But now the regulation landscape is changing a bit, and you actually have to like validate it as you should. So that's like a long-term goal. But what we're doing very importantly is, I think, thinking about all the other things apart from genetics. So medical history, like your phenotypic data on how you reacted to these medications, prospective data on patients as well. Once the prescription is made, actually how you're feeling in a month, 3 months, 6 months. So creating this unique data set that doesn't exist right now. We looked at like biobanks and data sets that currently exist, and no one really collects like granular information on response to hormones and contraception, because it's not very difficult. It's very difficult to actually study side effects of medications and attribute something to a medication. It needs to be very like high quality, a lot of questions, like really teasing it out. What is the medication side effect? What's not? So basically what we're doing over the next few years is, as we launch in the platform clinics, we'll be collecting this unique data set on women's experiences with contraception to be able to start teasing out those correlations. Is it something in your lifestyle, in your medical history? Is it genetics? All of this together, like be able to predict the response. And actually we've been running studies so far on the side. And
are you going to give us an inside scoop here?
So
something you found.
Give you some insights. So even in the medical history, so PMS makes sense that women with PMS, so premenstrual syndrome, would be at higher risk of developing side effects. This is what we found, for example, in the phenotypic data, which seems very obvious. People, could be like sensitive to hormonal fluctuations, hence they have PMS, hence they could react badly to contraception. But not much research has been backing this. Not much research has been done on this before. Another one is we found that there was some genetic variants related to neuronal developments that were actually linked to side effects related to mental health, which is another very controversial topic, and we haven't been able to, have a conclusion on, mental health and contraception. But again, we think that for some people with risk factors of specific, maybe genetic or other issues as well, they might be actually at risk of developing those mental health side effects. Aaron has found some things in estrogen receptor genes as well, which were linked to weight gain. Another very controversial topic that was, is there weight gain, is there not? He was actually showing with women with this specific variant were more likely of getting weight gain as a side effect. So still loads to be done, but there's definitely something there. And same as, for some women that stop contraception and they can get pregnant in a week. And some people, it takes like months and weeks to get pregnant. And it's another thing of like how we actually get back to like our like natural hormone fluctuations after contraception and how sensitive you are to that sort of axis being shut up. So definitely something there that we need to keep investigating. but probably a long journey.
The preventing pregnancy. I suppose as you go through your life, your wants and needs start to maybe change, and it's going to be different for different people. But generally speaking, most people don't want to have children too early on in their life, right? Like the sort of teenage pregnancy scenario is generally considered undesirable. And then probably as you start to advance in your life, you might suddenly be a little bit more interested in having a family. Again, I don't know about this stuff. And then there might be men out there like me who are in relationships that have sort of ideas of maybe they're with somebody and they'd like to have a family with them. What should they know about contraception and its impact on their partner's ability to have a child?
Yeah, good question. Also a lot of potential controversy around this in terms of, does contraception really impact fertility? So studies have been showing that no. So once you stop contraception, you can go back to your natural fertility levels, you would say, but actually there's other things to come into play as well in terms of, for some methods, and as we just discussed, it takes a while to get your fertility back to your natural level, but the natural level also will be different because you've aged, right? With time, that is the biggest thing about fertility, right? And egg quality, and that's what the whole idea of around egg freezing is about, that actually with time we lose a lot of eggs as women, and we actually the most eggs we have is before we are born, and then every month, every time we cycle, we lose 1,000 or something like that. So with age, not only we lose eggs, we also lose the quality of eggs. So maybe you've been on contraception for 5 to 6 years, and the contraception itself didn't affect your fertility, but actually you might be now 36, and actually your egg number is way lower, and the quality of your eggs is lower as well. And there's a huge variability between people as well, how quickly you age, in terms of your ovarian aging. It's actually fascinating because, I'm saying 36, it's a super young person, right? But actually their fertility may already been impacted to the level of they might be starting to struggle with fertility and getting pregnant. So it's very, very individual depending on the person. And now I think there's more and more people actually thinking proactively about this and actually doing some testing. You can check for fertility hormones such as AMH and check your egg quality and number as well. If you do an ultrasound and go to a fertility specialist. But again, one-off test can help, but it's not going to predict, right, your sort of fertility outcomes and whether you can get pregnant in the next few years. But there's definitely a lot of couples now thinking a bit earlier about, if we want to have a child in 5 years or maybe sooner, do we need to do any testing for both, right? Because actually a lot of infertility also is on the male side. So there's a lot of things that you can sort of start thinking and planning ahead if you were to find out that actually I'm at risk of earlier menopause, or I'm at risk of having issues with getting pregnant. And definitely people that have underdiagnosed gynecological conditions like PCOS and endometriosis, that's also another issue where you might find out about the condition when you're starting to get pregnant and you can't get pregnant. So there's a lot of people that are now just more proactively doing some testing and going to gynecologists to just see, I've been on contraception for 10 years, but I don't know, maybe I had underdiagnosed endometriosis. I just, it's been managed with contraception. So that's another reason to just have a sort of proactive check with the doctor as well.
It sounds like there's just so many variables, and I don't know how possible it is to account for all of these. Is that the reality of DAMA? That you're trying to really sort of put it under one umbrella and say that we're trying to streamline and give you the best possible guess? Exactly.
Because every time I'm trying to answer these questions, it's always it depends, right? Because for every individual it'll be different. So that's the whole sort of vision that we have, that actually in the future we'll be very much looking at a lot of data about you. And now we're doing so much better in terms of health data. We have the wearables, we have so much more we're collecting about people and patients. I think definitely in the future we'll be analyzing a lot of data about an individual to help them make that decision. Because it's true, when when you're making a decision about contraception, it's right now, but also me in the future, right? It's also going to potentially affect my relationship, my fertility. So it's a big decision to make, actually.
And when you're talking about sort of fertility, I think earlier you also mentioned menopause and sort of predicting early menopause, and there's massive variation in women's ages.
Yes.
Who go through sort of perimenopause and early menopause. how would you say, what's the evidence out there, or what do you think you would want to tell people around, can they start predicting anything about early menopause? Because many women my age, rock up at their GP often doesn't know so much about menopausal symptoms because we are perhaps the first generation to talk about it. So I commend us, all women of my age for that. But I guess, how do you, or what is out there that perhaps we could know that is in the research, and maybe DAMA Health one day will also move into menopause?
Yes, I'd love that. It's actually really bad. I think menopause research is even worse than contraception research, because honestly, the best predictor we have right now of menopause age is at what age did you get your period?
And your month, yeah.
So there isn't anything it's great, asking your parents, because it gives you a bit of a genetic idea of your scenario as well. But there's research looking at genetics as well, and I think they were able to predict with 60% accuracy the window for 5 year around menopause age, but it's still 60% accuracy, right? So we still don't have something that is really accurate in predicting early menopause and menopause age in general. There's definitely things showing that lifestyle interventions can help with ovarian aging and having menopause at a later age. But you really don't know much. I really hope that with some trends that we'll be seeing, there's 2 trends in contraception that we want to see. So people coming off contraceptions and starting their fertility journey, but then actually 3. So after pregnancy, starting contraception, and then that window of time when you're stopping contraception, starting menopause as well, the correlations between how you reacted to contraception versus your experience of menopause. I think there's quite a lot to learn as well of how we go through different life phases and how you reacted to certain hormone change in your life, and what does it mean for the next change that you'll have in your life as well.
A lot
of unknowns. I'm not giving you much. A lot of unknowns.
I'm listening to all this, and I mean, probably the answer is not really going to be there. But I mean, I'll ask both of you, if we were to sort of drift into the land of infinite possibility, it does sound like women's bodies are significantly more complicated than men's bodies, right? Is there a future in which we have a greater capacity to sort of control the variables, and even to such an extent that somebody would be able to offset something like menopause?
Mm-hmm. I'm a startup founder, so I'm a very enthusiastic person, and maybe maybe too optimistic, but I really think so. Contraception, to be honest, as well, gives us that it's a bit of a biohacking tool, actually, when you think about it. For people that are as I mentioned, athletes, and they don't want to have periods, they can take contraception, not have periods. It's there's pros and cons to everything, but it's a tool that we have that can we can have the autonomy of what we do with it, right? And it's very individual. Same with menopause. I think we'll get to a stage where we maybe can decide if we want to have menopause, and when is that menopause going to be, in terms of right now we have sort of painkillers for menopause, right? So we give HRT to so hormone replacement therapy, because we don't produce hormones anymore. But actually with time, I think we'll have novel therapeutics that will help us preserve the function of ovaries to continue produce the hormones for longer. I hope so. So maybe it will be just a choice. And some people like to go through menopause, because a lot of people want to have that very natural progression of everything. No hormones, no HRT, no contraception. So it's, again, super individualized, but I think so. I think we'll be able to choose what type of treatments we want for HRT, for menopause, or maybe not have menopause at all. That would be amazing.
Well, yeah.
I think there's so much more that, in terms of menopause and ovarian aging, it's actually, ovaries are not just to produce babies, right? There's so much more function in them in terms of cardiovascular, cognitive, bone health. And maybe we can preserve that, even if the fertility is not there anymore as a function in terms of eggs and stuff, but actually we can preserve we'll see. I don't know, again, super early.
Yeah, no, you asked about sort of infinite possibilities. Look, I agree with you. I think that the future is far exciting. But I guess just to kind of take a step back and ask the question, well, why do we know so little about female health? Yeah. I guess to put that in context, because otherwise it does sound like research has completely ignored us females. But the reason that we were ignored was through a valid medical reason, right? Because loads of medications were tested on young university men, because it's always that kind of age group that kind of turn up and get paid for studies. And obviously they're young and healthy, so you're only varying one variability point at a time. And all medication is directed to them. They don't really need medication because they're all young and healthy. But that's the story of all medications, and that's in part because, you know, of young healthy females were of an age where they might be carrying babies and they didn't want to take any sort of risk to the child. And of course now research has developed. It's mean that we're able to test on men and women, and we're able to get a much more holistic sort of viewpoint in all sorts of different varying ages. And all of a sudden, all that we thought was true that we learnt at medical school, some of it's turning out to be quite different from you know, A does not always equal B. And so therefore, as a result, as we gather more information, more clarity, we should, and you know, that's what's exciting, to be living through these times. At the same time as saying that, I think that it is, you know, we should remember at a societal level, number one, birth rate's actually going down. So the more choice you have, doesn't mean to sort of say you're choosing to have a baby, but you're right, the chance of having personalization of anything is, in theory, going to be, you know, I mean, that's going to be the revolution, isn't it? To be able to sort of say, no matter what medication you're taking, it should be personalized towards you. And so it's great that, you know, you're doing it for DAMA Health and for the varying ages of females over time.
Absolutely, and that's about, it's very much true. It's very valid reasons why, like, medical risks in terms of women being excluded from the studies, right? And there was a big scandal of a medication that was affecting pregnancies and babies in 60s, I think, or 70s, and then stopped, women stopped being recruited to clinical trials after that because it was, you know, babies were affected, and actually it was a very valid reason why we kind of were so skeptical. But just left us a bit of a lag in terms of studying medications and therapies.
Yeah, it's left all this dirty data, right? Because the data's all on one specific cohort of people.
But we have the same issue actually with ethnicities as well, right? When we actually study usually white people, and actually huge differences in how different ethnicities, people from different backgrounds react to medications differently. And actually it's really great to, now that we know, it's just that we know, and now we have to do things differently. For example, the male contraception studies, they are actually already looking into ethnicity and actually showing that, I think, from like South Asian backgrounds, they were more prone to develop side effects and metabolize those novel methods of male contraception differently. So it's like what we've learned from the past of, like, you know, not accounting for the diversity, and now can we do things better in the upcoming studies?
Yeah, no, look, I completely agree. Although, again, there is a reason for it, right? And if you sort of go back historically, I used to work at a university hospital, and we used to kind of get people to come and sort of cycle on their way to see us for a study trial. So, you know, you had a very microcosm of people that you could actually study. So it's not the fact, you know, I think as scientists, they haven't wanted to investigate the world, or they haven't wanted to try and make it full across at different ages. It's just that you have a very micro population base, whereas now, as things have digitalized and as more people are willing to join clinical trials, because again, that's a big ask of people, then yeah, hopefully it can just make the data richer, better, and that's better for everybody.
We were actually so excited to see in our study, we recruited 1,000 women to do actually saliva tests for genetic study in like 2 months. And it was amazing. We were like, you know, oh my gosh, this is going to take us so much budget and time. And there's just a huge, like, I think, willingness to help and willingness to support this research for women, right? Like just wanting to participate and help. And, you know, just giving the saliva for genetic research studies, like, was really amazing to see that sort of movement of actually, you know, people sharing stories and telling us. We were like, just doing a genetic study, looking at the phenotypic and genetic data. But actually, we also gave it like a little textbook if you wanted to share anything extra. And we got so much data from it that we actually wrote a qualitative paper just from that box of like extra data that came through. Like, people are definitely willing to participate now, and we have a opportunity to engage people more in studies now as well.
Another question, though, on the sort of trusted clinician, you, I guess, which is a bit unique to kind of contraception, or at least that as a business sort of side, is the ages. Because, I mean, you think you said at the beginning that, you know, it's often sort of 16-year-old girls, 17-year-old girls that are coming in with their mum or their dad, I'm sure, or with a friend or something. But how do you sort of see that evolving? Because it's a very sensitive topic. If you're 16 or 17, you probably haven't even been having periods for very long. Hormones can be very fluctuating. I mean, they don't even get measured, right? Because you can't do it. There's nobody that's doing the continuous.
Oh, we are applying for a grant to do this, like a CGM to do. That's what I would love to see this in the future. We're applying for a grant to be like a CGM for for contraception.
And so your CGM is basically like a blood glucose monitor, but this time for
hormones. It's difficult, but there's like a bioengineering company that we are good friends with, and we're thinking like in the future, imagine we have an implant that both measures and delivers the hormone. Because this is very like Star Wars futuristic. But going back to teenagers, and I think this is definitely like there's a specific group of patients that have very specific need in terms of the education, and the adolescents are definitely part of that in terms of maybe it's not the doctor that is the best person to speak to them about this, right? It's actually
not in 10 minutes, right?
Exactly. Exactly. It's more of a TikTok style content that we have to produce to engage.
Just a tick box, not even TikTok.
Absolutely. We've got some feedback that it's like, when you use the platform at home in your own time, it's like a bit more discreet and you have time to think through this. But I think there's so much more we need to do to like really cater that population. And we've done testing of patients that were like different age groups, and actually like definitely the most positive response was from the younger group because they wanted to learn. They're very used to engaging with technological platforms to read and watch videos. We had all of that in videos as well on the platform. But there's definitely a thing that's thinking about how can we make content that's actually engaging. That was difficult. Like how do we? It probably needs to be like TikTok style because otherwise they're not gonna engage with like medical articles and on methods.
This question, I actually don't know if I should ask it or not.
No. Go on.
What has been your personal experience with contraception?
No, happy to share. So I've, as many people, when I was like 17, I was put on a combined pill, and then actually I was all right back then on that pill. I was like, actually this is fine. I know what all these people are talking about in terms of side effects, but I also didn't know what the side effects could be, and I didn't really know that I was actually experiencing side effects. So it's an interesting thing that I think a lot of people, I think there's also a statistic on this, I think around 30% stay on contraception and they don't know they're experiencing side effects because they think it could be bleeding, it could be libido changes, it could be mental health changes. Like you don't know if it's you or is it the pill. So I was on a combined pill for acne actually mostly, and just again my mom and we like get on the pill. And it was fine, but then I changed it here because I moved to UK, so they didn't have the exact pill that I had. Wasn't feeling so great on it, so I stopped it. And now I'm going through the phase of I'm learning, and I'm actually waiting to analyze my genetic data from the study because we kind of left ourselves towards the very end to make that decision for myself. I'm most likely going to do an IUD, but I'm still I'm going to wait for my genetic data to see if there's anything I can deduct from there. Very early research, and still learning. I'm doing research on the sort of IUDs are very difficult because most studies are done on like combined pills. So when I'm thinking about like what's the impact on everything else I do, on my lifestyle, again, on like my future health and fertility, IUDs are not usually studied. It's usually the combined methods that are studied in terms of like the impact on the other areas of health. But I think my right now my guess and my educated guess from the research we have is that I would choose IUD for myself. But this is a very sort of individualized decision.
It's super fascinating though, because if you were to choose that for yourself, how can you so two questions I have. Firstly is like, how does the waiting for your genetic data, how is it going to, what are you going to learn? Because I'm super interested in that. And secondly, even once you've chosen your method, I suppose, there are different brands out there with quite significant differences. Yeah, so how do you, you're an educated individual that's dedicating your life pretty much to this, right?
It's still hard, exactly.
Yeah, it's super hard.
It's super hard. So with the genetic data, I'm going to look for the variants that we have as like this sort of variants of interest that we have, like, and they're not yet, no,
I get it. They're not fully studied, but what are your kind of insights into that?
I'm still going to have a look. So I'm going to look at like the trends that we've seen in terms of what side effects people develop with these specific variants. And then I'm going to look at my blood risk as well to see if there's anything there. Right. And then there's also like other genetic factors that I want to look into, kind of like not related to contraception, but generally like my medical history as well. So just to have the whole picture there. But it's very early on. I just have to like think, look at this, and this is what we have in the study, but it's with a pinch of salt of like, is this actually going to be confirmed in the later studies? But just to have the insight that I can have. And the formulations on IUD. So the way I'll be taking the decision is that actually I don't particularly want my periods, so I'd probably go for a higher dose of IUD because I like exercising, I like going to the gym, and every time I have my period, I can't really fully exercise very well. I wanted to ask you this about actually when you like do personal training with women, or do you have to adjust to the phases of cycles? But yeah, I think that's where I'm gonna come from in terms of like I'd probably just prefer not to have the period and like go for a higher dose that will give me a higher chance of my period stopping. But a lot of people do like to have that sort of ovulation with, you can actually have ovulation still cycle with IUD, so people prefer that as well. But that gives you higher chances of irregular bleeding. I think that the bleeding of IUD is one of that I'd love to be able to predict. Like that is the main thing with IUDs of like, can we predict if you're actually going to have irregular bleeding for the next year, or is it going to stop in 2 cycles? Don't know. Don't have the answer.
One day.
One day.
How far are we away from, and before I ask that question, just to like get clear on DAMA. DAMA is an app?
It's a web app platform. So it's embedded in the sort of clinical flow the patient get to use. It's basically they can get it on the phone or on the computer, but it's a web app platform rather than an app.
Okay, so if I'm a user of DAMA, I'm able to log on either through my phone or my desktop, and like, what does that actually look like to be a user on that platform? Like step by step, what exactly is the experience that I'm going through?
So if you're going to see your gynecologist, a primary care doctor for contraception, they will ask you to sign up to DAMA. So it's all embedded in that flow. So you'll get an invite to join the DAMA platform to do your holistic assessment of contraception needs. And then you go through our assessment before you visit the doctor. So you answer all the medical questions, you answer your lifestyle questions and goals. That's where we see people spend most time on these questions. And we sort of educate people as we go along through this assessment. And at the end, you get your personalized insights of things that were relevant to you for all contraceptive methods. And then you go to see your doctor to make a shared decision. What we have on the roadmap is now create a sort of what happens after that contraception visit. So to actually bring you back to the platform, not constantly look at an app, because we think this is too much to give people another app to track symptoms, but actually just like regular check-ins to collect data on, are you still using that method? How are you feeling? So have that sort of ongoing care after as well. In the future, we'll want to add genetic testing to it. So we're still mapping it out.
How does that communication occur? Do you email them or?
Yeah, email and text, yeah.
Okay, so it's sort of
same as you would get from your doctor. Like this is the same portal actually.
Right. Okay. How far are we away from that being like common practice for, let's just say, women in the UK?
So we are not actually doing anything in the UK right now. What thing we would need to do is have a clinical study showing cost effectiveness of a platform like this, that it's improving adherence to contraception, that women are actually like their contraceptive method that they chose with the use of the platform, and their symptoms are better, like on average compared to the status quo, to be able to show the cost effectiveness to the system. I think that's maybe when we're gonna look back to the UK once we've done these studies to show actually there's like better clinical outcomes if we use a platform like this. And what we want to do is always have like 2 sides of the product. So one will be just the digital, so it's way more affordable, and digital software is like actually quite cheap in terms of running with this, apart from the integration with the EMR, and the version that has the genetic testing as well, so you can add it on. And we think initial stages is that actually it will be a decision between the patient and doctor again whether you even want to do the genetic testing. So it will never be like very expensive always altogether. It's always going to be like both, like, and genetic can be an add-on to this equation. As you said, there's so many different factors to consider, so genetic could be like an extra layer of information that you're considering, but it doesn't have to be if you don't want to opt into that, or you can't afford to opt into that as well. And to reimburse genetic testing, I think that's a really long-term horizon. It's probably one day in healthcare systems. I think there's countries around the world that are trying to like sequence everyone and like population level sequencing.
We're trying to here, right? It's just, we're trying to get to 5 million people to sequence. So, but you're currently, what's America? Is that where your main cohort is, right? Correct.
Yes, for now.
But it's such a shame that if you've done all these kind of videos and educational sort of side, because it sounds like that could be another thing. It's called a modular system, isn't it? The education system could be something.
Could be, absolutely. With the algorithm and everything, like all I would need to do is just translate into UK guidelines. To be honest, it started as UK guidelines, and then we realized actually let's focus on one market. Let's focus on on where the opportunity is. But definitely, like the moment I have more resources, very easy to. We want to translate into Spanish as well for the populations in the US as well. We can translate to other languages. Could definitely be launched. And it would, like, to be honest, kind of would be the whole circle back to where it's all started for me with those GP clinics, right? And it would make so much sense. But I think, we haven't quite gone down the road of like, let's try to get NHS to cover costs for it just yet with the current sort of, priorities that an NHS has. I think like personalization may not be high on the agenda, but maybe one day we'll circle back.
Well, that was coming into this conversation. I mean, like I said at the beginning, and probably multiple times throughout, no clue about any of this stuff. But it does sound like it really does matter. And, obviously women make up such like overwhelmingly large percentage of our population that there's this whole thing affecting them. That again, I'll probably speak for most men, if not all, that we don't think about this stuff, right? But it's not to say that it wouldn't matter if we know about it. Is there anything that we didn't touch on in this conversation that you feel is important for us to know?
As in, we could talk a bit more about this sort of, like being involved as couples, right? And males in the conversation as well. I'm actually definitely seeing this more and more. Like, my friend has this app and there's a button, do you want to share this with your partner? And it's like tracking her menstrual cycle. And she was like, I want to share it with my partner. And he was like, okay. So now she's sharing her symptoms and fluctuations through the month. And so I think it's definitely conversations becoming a bit more shared. And as we have those male contraceptives coming to the market as well, there's research showing that males that were most interested in these methods were the ones that were in long-term relationships, and the main reason why they wanted to take part in clinical trials was that they wanted to take some of the burden off their partner. And because the methods are being novel and they're only thinking in terms of how can we mitigate side effects for males. So like there is a hope that these methods will be like highly effective with low side effect profiles as well. So people, I think, just being a bit more hopeful that actually that method will suit them even in the clinical trial. So it's very interesting to see that trend of new things coming to the market and people being more involved in the conversation as a couple. And I think maybe one day we can add these methods as well to the platform. That's actually not just a women's assessment, it's actually like a couple's assessment as well. Like there might be different pathways to get into that discussion. Maybe the answer of the algorithm is actually going to be like your partner should be on the method. I don't know, maybe it's something that is going to be more holistic as we have those male methods coming to the market as well.
And maybe it will also translate into male hormones, because we've spent a long time today talking about female hormones,
absolutely.
But men have them too.
Absolutely,
so,
absolutely.
Yeah.
We have this medical advisor that he is one of the researchers on male contraception, and he was saying that we'll have the same circle of issues where we will develop male contraception, and then we'll see some men have side effects, and then we'll have to figure it all out. So like we could basically do the same thing exactly that we're trying to do for women as well, to find the best method when they are out there.
Great.
All right. Well, I've decided to do something new on the channel I haven't done before. So you're probably going to be one of the first people to experience it. Okay. But I wanted to end the conversation with something, potentially unrelated to the topic that we've discussed. I'm a very introspective individual. And I guess I'd like to encourage other people to be introspective as well. And so I wanted to ask a question that I think would probably be something that gets you to think. If you had a chance to relive one day of your life, what would it be and why?
Relive one day of my life. Okay, let me think. Bringing to you very interesting. Yeah, just pick them out. There's a few that come to mind. I'll just go for the first one that came to mind. The first one was the day when I came to London for the first time with my parents, and I just felt like everything was changing, and I was then here with them, and it was like a very I know like the transformational day of like my whole life is changing. Like I'm moving my life from Poland to here. And they were like super supportive, and I just felt like I can do everything. And it was just, you know, very like quality time with my parents. That just the first thing that came to mind. But I'm sure I'll think about it more as I'm getting home. Just maybe back for a deeper answer to the question.
Yeah, I just want to say thank you for sharing all of that with us. I always get a lot from these episodes, especially when it's like an area that I've never really had to consider. And so it opens my world up massively. And it's certainly not going to be something that I, you know, go around to every woman in my life now and start asking them about how they deal with contraception. But to at least be aware that that's a factor in their life is probably quite an important thing for me to do. Michelle, do you have anything to...
Just a thanks for bringing female health, new businesses, and looking at it from a globalized perspective. It was really insightful. I really enjoyed it, and it was just lovely to have you here. Thank you.
All right.
Thanks.